Hello everybody, my name is Aditya Daftari and this is the talk on pediatric knee variants and common pathologies. I've taken the liberty to reduce this talk down to the 5 things that strike me or the 5 things that I look at or see commonly when I'm looking at pediatric knee radiographs and MRIs. The way I've structured this talk is to look at the 5 common areas where I find abnormalities that are typical of children. So the first is periphyseal regions. The second is the patella. The third is the tendons and the apophyses. The fourth is the menisci. And the fifth is the ligaments. It's important when you start looking at radiographs of kids to have seen a fair number of them and have a good sense of what normal and abnormal looks like. So here's an example of a normal knee radiograph in a younger individual. You can see the metaphyses, you can see the physes. So you can see here the metaphyses, you can see the physes, and you can see the epiphysis. This is the diaphysis. The first and most common thing that we see is when you see diffuse fraying and splaying of the metaphyses, and you see that pretty commonly, unfortunately, in our country in a condition called rickets or vitamin D deficiency. Another thing that we often see in these patients is we see healing rickets, fortunately, and so we see more of sclerosis along those areas where there was fraying. A condition that's fairly common to younger kids, where you can get them in early or late stage, is Blount's disease, where you see, because of supposedly abnormal loading patterns, you see increased loading along the medial tibial metaphysis, and you can see fragmentation and downsloping in somebody with Blount's disease. Other things that you should be aware of, sometimes you can see little corners in the metaphyses, in which case you should be alerted to look for non-accidental injury or metaphyseal dysplasias. You can see the typical findings of scurvy, where you can see Pelkan spurs, or these little metaphyseal spurs over here. You may see subperiosteal abscesses and periosteal elevation. You can see the white line of Frenkel over here, and you can see the Traumerfeld zone, which is a lucent area just deep to the sclerotic line of Frenkel. Rim-like appearance to the epiphysis is known as a Wimberger's sign, and these would be classic of scurvy. We see scurvy fairly infrequently, but we do see it occasionally. If you see marked irregularity and distortion of the metaphyses, but you notice it on both sides of the knee joint, then it could be something that is more diffuse, something like a skeletal dysplasia. In older individuals, the findings are a little bit harder to pick up, but there are 2 types of abnormalities that have been described in rickets. One is the subcortical cystic changes, and 2 is the metaphyseal lucent areas, which we can see in older individuals with severe vitamin D deficiency. When we see metaphyseal bone resorption along with periosteal elevation and periosteal reaction, one can see scurvy, and we occasionally come across these cases. Whenever you're looking at a child with knee pain and you can't find anything, always remember to look carefully at the physes. You will occasionally notice areas of the physis that are fusing as compared to the rest. If there is no pain associated with areas, it's usually nothing. But if there is pain that is attributed to that area, one should look carefully. And I'll show you what this case turned out to be later in this talk. You can sometimes see sclerosis diffusely in the metaphyses, with irregularities along the epiphyses and the metaphyseal region of the epiphyses. If you see this in multiple bones, if you see this on both sides, then you have to think of an entity called chronic regional migratory osteomyelitis, or the current term which everybody uses, non-bacterial osteitis. And last but not least, remember that the area around the knee and the metaphyses around the knee are fairly common areas for people to develop osteosarcoma. So if you see sclerosis, and you see especially that sclerosis or osteoid bone formation going into the adjacent soft tissues, you must start to think about osteosarcomas. So this is again a brief overview of the things that we've talked about. Scurvy with the classic spurs, the subchondral sclerosis, the subphyseal sclerosis and lucent bands, as well as the Wimberger sign, which later on may develop into subperiosteal lucencies, metaphyseal lucencies with periosteal elevation, chondrodysplasias, which are just diffuse abnormalities affecting multiple bones, metaphyseal dysplasias, where you can get these little corner elevations, Blount's disease, which is typically affecting the medial proximal tibial metaphysis, rickets with splaying and fraying of the metaphyses, which later on with healing may go on to just form sclerosis. Anytime we see changes in the corners, always to remember to look at the other bones for the classic injury patterns like the bucket handle metaphyseal twisting fracture of a non-accidental injury. And remember, this is an area as a radiologist you can make a big difference. Diffuse sclerosis of bone extending to the metaphyses, especially affecting both sides of the joint or even one side. Remember the inflammatory bone disorder of non-bacterial osteitis and also the bacterial disorder of osteomyelitis. Now, another thing about the metaphyses, when you look at them on MRI, it's very important to remember that there are a lot of metaphyseal variants. So you can have bone edema on both sides of the metaphyses as the metaphyses are fusing. And if you see there's no pain in those areas, then this is simply what we call a FOP zone or a focal it's basically a focal periphyseal edema pattern. You can see oftentimes a little lesion here. Now, this is abnormal metaphyses, but I'm going to talk about that later. But you can see this focal bone lesion here at the back, especially along the medial femoral condyle, and that is called a cortical desmoid. It's a normal variant that we see very often. And the third is this posterior metaphyseal stripe. So along the posterior cortex, you can see edema deep to and superficial to the cortex. So these are common variants. If nobody has pain associated with these things, these are just incidental findings. The abnormalities that you can see is sometimes you can see those cortical bone marrow edema happening more anteriorly. And when there's pain attributable to this area, as there was in this child, then this could be a stress reaction. You can see areas where there's patchy periphyseal bone marrow edema, subtle subphyseal bone marrow resorption, and this would be typical for a case of older rickets. You can see diffuse metaphyseal bone marrow edema, oftentimes with additional periosteal bone marrow edema in patients with scurvy. You can see again subperiosteal bone marrow edema, but with a more spotty, irregular pattern, almost with the little cystic areas, almost you can think of as metaphyseal abscesses almost. And this could happen on both sides of the joint. This could be symmetric, asymmetric, and that can happen in non-bacterial osteitis. And then this is the case I showed you earlier where we did an MRI and you can see this abscess within the metaphyses with the bone marrow edema extending anteriorly along the tibia, and this ended up being a typical bacterial osteomyelitis. Last but not least, when you have all these periphyseal abnormalities, you can have abnormal fusion across the physis, and here it's important to look at the physeal bar and to talk about what the size and extent of that physeal bar is, because the physeal bar has potential to distort growth, and then people can do procedures that help in improving or changing the way the bone grows by applying clamps, narrowing down or preventing growth of the physes and maintaining the congruency of the bone. So here again is a summation of all the metaphyseal MRI findings. The normal FOP zones, again, no pain, it's a FOP zone. If it's pain, it's stress reaction. The cortical desmoid, the posterior metaphyseal stripe, rickets, scurvy, anterior cortical stress reaction, non-bacterial osteitis, and then finally the physeal bar. So if you think about metaphyseal evaluation, think about the x-rays. We've talked about rickets with early fraying, splaying, and cortical thinning. We've talked about the later stage where you see sclerosis and the metaphyseal lucency. We've talked about Blount's disease, where you can see medial proximal tibial metaphyseal buckling. We've talked about the metaphyseal corner irregularities, which should make you think of skeletal dysplasias or metaphyseal dysplasias, non-accidental injury or inflicted trauma, scurvy, which is essentially with the sclerosis, the lucency, the periosteal, and cortical thinning. And on MRI, the things that you think about are going to be things like the normal variants of the FOP zones, the cortical desmoid, and the posterior cortical metaphyseal stripe. You think of stress reactions, which you'll think of rickets, where you have metaphyseal bone marrow edema. You'll think of scurvy, where you have metaphyseal and periosteal bone marrow edema. And in rickets, it is metaphyseal as well as epiphyseal. You can think of things which are like non-bacterial osteomyelitis, and then you can think of proper osteomyelitis. And last but not least, as a sequel of all these things, you should look at the physeal bar to determine if there is a physeal abnormality there. Moving on to the epiphyses, where normal epiphyses are fairly smooth. You can occasionally see irregularity of the epiphyses, which is a normal variant. It may be fairly gross, where you end up seeing flattening, and this is just because of the way the secondary ossification center ossifies. And in this situation, you can see here is the normal femoral epiphysis, but in this normal variant appearance, you can see a rather fragmented appearance to this epiphysis on the sagittal and coronal images. And this is nothing but a normal variant. The major abnormality that we should think about in the epiphysis typically is the osteochondritis dissecans lesion, which typically happens on the inner aspect of the medial femoral condyle. These are identified better on MRI. The key thing we want to determine is whether these are stable or unstable, and that is decided on the basis of whether there is bone marrow edema, whether there is a fluid rim between the lesion and the underlying native bone, and if there's a breach in the overlying cartilage. These can heal spontaneously, such as in this case, or they can go on to displace out and be fragmented and become unstable and come out of where they should be. Another entity that we occasionally see is the subchondral bone marrow edema. This can obviously happen with any of your ligament injuries, but also in patients who have just plain old epiphyseal stress. So with epiphyseal evaluation, remember the big one being the normal variant in the medial femoral condyle, especially because of the secondary ossification center. And then think about the OCD lesions, whether they are stable or unstable, and finally the epiphyseal stress reactions. The next thing we talk about is the patella. When we start looking at the patella, it's a fairly common area. Anterior knee pain is fairly common in children. So we start out by looking at the patellar position and size. You can have a low-lying patella in this case, which is the patella baja. You can have a high-riding patella, which is the patella alta. And the way you determine it is if you measure the ratio between the patellar length and the patellar tendon length and the patellar length, and they should normally be within 20% of each other for it to be normal. If it is too high or too low, then you would call it alta or baja. This is an example of somebody with a hypoplastic or absent patella and someone with Fong's syndrome or nail patella syndrome. We can also look at the lateral movement of the patella in patients with patellofemoral instability. So we start this out by measuring the trochlear angle. We bisect the trochlear angle, and then we draw a line from the center of that trochlear angle to the center of the patellar ridge. And that angle over there is called the congruence angle. And if that is below 16 degrees, then that's perfectly fine. The second thing we do is we draw an angle that goes along the lateral patellar facet. And if the angle between the lateral patellar facet and the lateral trochlea is what we call the lateral patellofemoral angle, and that can be 13 degrees plus minus for it to be normal. When we look at the patella itself, the most common variant that you should be aware of is the dorsal defect of the patella. And this is sort of a variant of the fusion of the superolateral aspect of the patella, the bipartite component. You can see a small defect there. It can look like a cyst on your X-ray, and even on MRI, it can look like a cyst as well as on CT. And the main thing to differentiate this from is when you have a large cystic area within the patella itself, which is T2 hyperintense. If there's extensive edema around it, you can occasionally see a chondroblastoma within that bone. And otherwise, if there's a lot of a joint effusion, then you should start thinking, could this be a geode or could this be an erosion, an inflammatory erosion of the patella? The second abnormality of the patella is fairly common, is the patella is the bipartite patella. The typical one is at the superolateral margin. We also have an inferior one, and you also have one here just along the lateral margin. So these are bipartite variants. Now, when you see a bipartite patella, the things that you should be careful of and you should not forget, one is whether that bipartite patella has edema at the synchondrosis or within the bone, which results in instability, which could be a problem, or that there's a fracture that you're missing and miscalling as patellar, you're miscalling the fracture as a bipartite variant. Now, that patellofemoral instability or patellofemoral dislocation comes with three issues that all of you should be aware of. The first is the effects of the dislocation, which are on the trochlea, the patellar cartilage, and the medial patellofemoral ligament. The second is the predisposing factors for patellar dislocation, which could be patella alta, as well as the shape of the trochlea. And the third thing are the decision makers in surgery, which include the TT-TG distance, which is essentially the distance between the trochlea, center of the trochlea groove and the tibial tuberosity, as well as looking at the actual alignment of the knee itself. And these things can help us make decisions on what happens next to these patients. So when we're thinking of the patellofemoral compartment, remember to think about checking the position. This may or may not have clinical relevance. We remember to look at the bone itself for its size, the absence, the shape, the presence of the defect. And for patellar femoral instability, remember that you want to look for the effects of the injury, the predisposing factors to the injury, and the surgical prerequisites. The next thing we're going to talk about is the tendons and the apophyses. And here we talk about stress on the tendons and the apophyses, which could be acute or chronic. These could be high or low intensity. If they are high or low intensity, acute things, you will see bone marrow edema. You can either see bony avulsion with pain, or which in case you get an avulsion fracture, or you can see periosteal avulsion with pain, in which case you have what we call a periosteal sleeve avulsion. You can have more chronic situations, which could be active, in which case there is bone marrow edema and fragmentation, which is what you see at Osgood-Schlatter's disease or Syndig-Larsen-Johansson disease. And it could be inactive, in which case you don't see the bone marrow edema, but you see the fragmentation, and this would be just an inactive apophysitis. So what does this look like on a radiograph? So you can have here just a little bit of fragmentation without anything else going on here. You can have fragmentation with Hoffa's fat pad edema and thickening of that patellar tendon at the tibial attachment on somebody with Osgood-Schlatter's disease. Remember that this patient and this patient, this one could be symptomatic and this may not be symptomatic. So X-ray is just the finding, doesn't mean anything as such, but the finding along with the clinical picture is what matters. And then this is an example of somebody with a patellar sleeve avulsion from the inferior pole of the patella. You can see these on MRI as apophyseal changes. So you see bone marrow edema at the tibial tuberosity on MR in Osgood-Schlatter's. You see bone marrow edema along the inferior pole of the patella in Syndig-Larsen-Johansson. You can see actual periosteal elevation here in a periosteal sleeve avulsion injury. And then you can see bony fragmentation in a patellar tendon avulsion from the tibial tuberosity. So again, just to show you these things, here's the relatively normal radiograph. Here is the one which looks like obvious Osgood-Schlatter's, and here is the MRI to go with that. Here is osseous avulsion from the tibial tuberosity. And then here an example is a periosteal sleeve avulsion. Here's the MRI showing you the periosteal sleeve avulsion. And then here is somebody who does not have periosteal sleeve avulsion, but just bone marrow edema in Syndig-Larsen-Johansson syndrome. So this is sort of the summary and overview of how you're going to look at the tendons and apophyses. The next fracture is the discoid meniscus, which is fairly common. Here the things to remember are when you see a discoid meniscus, you can see signal within it fairly commonly. You can see parameniscal cysts. You can see mucoid change within the meniscus, and you can see a higher preponderance of tears as compared to the other structures. You can also see these tears have complex flipped appearances. Another thing that happens with discoid meniscus are the mucoid changes, and these mucoid changes can increase or decrease based on stress loading, and therefore these patients may have more or less symptoms as a result of this. Things to remember with the discoid meniscus, they are usually lateral. 20% of them are bilateral. In the lateral version, the medial is relatively rare and almost never bilateral. They have a higher incidence of abnormalities that go with them. And whenever you see an isolated lateral meniscal tear, remember to look for a discoid variant. And the last thing is when you see mucoid changes, these can increase or decrease with time based on the loading pattern. The last thing I'm going to quickly talk about are ligament injuries or ligament avulsions. I'm not going to talk much about Larsen syndrome, which is an absent ACL. You almost never see it. But the key things about ligament avulsions that you should remember are always the bone is the weakest link in these patients. So you often see bony avulsion. They want to know how big is the bone. They want to know how much it has been displaced. And this helps them to decide whether they are going to fix it or just immobilize it, whether they're going to use a wire or a screw, or whether they're going to actually have to reconstruct the ligament, and then how they're going to spare the physis in that reconstruction. So finally, we've talked about 5 different things here. We've talked about looking at the physes, the metaphyses, and the epiphyses. We've talked about looking at the patella, the position, the dorsal defect and cystic changes, and patellofemoral instability. We've talked about the tendons and the apophyses, where we talk about acute and chronic loading. And we've talked about the menisci, primarily the discoid meniscus, the tears and degeneration, and the way those things happen in these discoid menisci. And then finally, the ligaments, where we talk about mainly bony avulsions and the reasons why they want, what they want to understand about those bony avulsions that help them decide in management. So with that, I'll stop. Thank you for your time.